All right. Good morning, everyone, and thank you for joining. Today's session is called The Aging of the American Workforce, and we'll explore how this demographic shift impacts employers and employees alike. But first, a few housekeeping items. This session is going to be recorded. Attendees are going to be muted, but please use the chat and the Q&A tools. You should see them towards the bottom of your screen. We're going to be monitoring these and we'll have time to address questions at the end of the presentation. So feel free to type away. There is going to be a brief 5-question survey at the end of the webinar. So if you can take a moment and provide your feedback, that's going to be really helpful. My name is Martha Barker, and I manage the benefits department at Catapult Employers Association. We are in Charlotte, North Carolina. And today I am joined by your friend and mine, John Leary, and Eric Black. Also, he can be your friend and mine. He is with USI. Together, we're going to explore how employers can support Medicare eligible employees and leverage Medicare as part of the broader corporate strategy, including how HRAs can help cover premiums and healthcare expenses. Eric is also going to give us a look at what they're seeing on the broker side of things. And along the way, John is going to provide perspective on the bigger picture strategy. We're going to cover market insights, trends, and everything with the goal of giving you practical takeaways that you can use in your organization. Alrighty, before we dive in, I would love for John and Eric to introduce themselves and give us a little bit of background on who they are and what they do. So, Eric, we'll go with you first.
Thank you, Martha. Good morning. I'm Eric Black with USI here in Charlotte. Hope everyone is doing well. So USI is a large insurance risk management firm. We specialize in property and casualty insurance, personal lines. I specifically work in the employee benefits arena, working with companies in size from 50 employees up to the thousands of employees, fully insured to self-funded. So happy to be here to talk about this very important topic. And John, turn it over to you.
All right. Thanks, Eric, and thanks, Martha, and thank you all for attending today's session. My name is, again, John Leary. I am the founder and CEO of Health Perspectives. We are a Medicare advisory, providing advice and guidance to both employers and to employees. I have a 30-year history in the healthcare industry in a variety of different roles. That includes health administration, healthcare administration, health insurance, primary care, and a variety of other health-related initiatives. And I enjoy working with employers to help resolve some of their health-related issues and costs. And that's what we're here to talk about today. So with that, I will get started and talk a little bit about the aging population. So as Martha indicated, I'm going to provide a broad overview of what's going on in our society and in our workplace. And I'm going to start with this slide, which, as you can see, is the population that was over 65 in a variety of different decades. So for the past 100 years, starting with 1920 and moving through 2020, it shows the number of folks that were over 65. And you'll notice that for most of that century, it was a fairly even increase from one decade to the next, about roughly the same percentage increase, except in 2020. There was a big jump in that decade, and as you probably will surmise, it's due to the baby boom population. So by 2020, roughly half of the baby boom had achieved 65 years or higher. So that's one unique aspect. The other unique aspect is that not only were the numbers growing, but the portion of the total population that was over 65 was increasing as well. So back in 1920, that 6 or 7 million people over 65 constituted 5% of the overall population. Well, that's changed over time. And by the time we get to 2020, it's now 17%, more than 3 times the percentage population over 65. When we look ahead slightly and go at 2030, now we're talking about another substantial increase. And I couldn't quite fit the percentage at the top, but it's 20% that is projected by the US Census Bureau, who provided this information. So whereas back in 1920, about 1 out of every 20 people were over 65, now it's 1 out of 5. And so that has repercussions across our society, but certainly as it relates to the cost of healthcare in our society. Well, if that's what's happening in the country in general, what's going on in the workforce? So the numbers that I'm about to provide come from the US Department of Labor, and it takes a look at the workforce participation of those 65 or over. At the beginning of this century, 2003, it was a modest number. There were about 3.2% that were full-time workers actively employed over 65. In 2013, that had increased a pretty sizable jump to 5.2. In 2023, again, now up to 6.7. And the US Department of Labor now projects that in 2030, almost 10% of the full-time working population will be over 65. So obviously that's beginning to have a significant impact on the workforce, the employees that are in that workforce, and the healthcare costs associated with that. There are a number of reasons why people are working longer, but this quote from Transamerica from about a year ago indicates that the perspective of the employers, at least a third or a little over a third of those employed workers, are expecting to work much longer than what is the traditional retirement age of 65. As you can see, these people are going to be working for a while. Well, if that's the raw numbers of people that are in the workforce over 65, let's look at the cost associated with medical care. So we'll start in general. And as you can see from this chart, probably not a surprise to anyone on the call. I'm sorry, let me go back. Not to anyone on the call, you can see that the CPI inflation has grown dramatically since the turn of the century, and we're now up 86% higher than we were in the year 2000. But the medical care index has also increased even more so. And so there's a widening gap here between the CPI and medical costs. So let's take a little step back and go back to October of 2022. And you can see at the bottom, there was a paper written by McKinsey and Company at that time, which they labeled the Gathering Storm, which was an anticipation of increasing costs of care looking forward into the future. And I'm going to focus on the two horizontal bars that are at the top of this chart in terms of what did they anticipate would be the impact on employers in terms of the cost of care moving ahead. For those agreements that were signed in 2023, typically a 3-year agreement, they anticipated it was going to be about 6% increase. However, for those agreements that were signed in 2024, a significant jump was going to take place, again, for a variety of reasons. So what actually happened? Well, here's an indication. This chart was put together showing the results of surveys conducted by a number of different entities. And back then, if you look at the typical trend, you'll see that prior to 2024, the trend that we had been seeing was about 6%. So right on the mark where McKinsey had predicted it would be. In 2024, excuse me, in 2024, that had increased to, on average, about 7.5%, according to these various surveys. The projection for 2025 was 8% on average. And then looking ahead to next year, I added another row here, and you'll see now you're looking at about 9%. I should also temper these numbers with the fact that these are typically large employers that are surveyed. Eric's going to share with us a little bit later on what the impact has been recently on the small and mid-sized market, which is substantially higher than what we're looking at right now. So that prediction from McKinsey has come to fruition, unfortunately, for all of us that are involved in healthcare costs. So what's driving these costs? What's really the impetus for this now surge in costs that we're seeing around the country? This is another survey that was done by the Business Group on Health in August of 25. It was published. And if you look at the chart to the right, there are basically three columns. The first column is what are the reasons for these costs being driven? And you can see that most of these are conditions or treatments for various issues until you get to the bottom. When you look at the last of these 7 cost drivers, these employers are indicating that because we have older employees, we are seeing increased costs. So it's no longer a specific condition or treatment. It is a segment of the population. In this case, it's older employees. And when this study was conducted probably about a year ago, 30% of those surveyings are saying this larger population of older employees, we're feeling that impact right now. An additional 30%, if you move to the right-hand side, are anticipating that they're going to be impacted as they see a larger share of their employees moving up to that level. And so they are anticipating that as many as 60% of the employers are going to be impacted by these older employees. So that's an overview of what's happening across the country. And with that, I will turn it over to Eric.
Thank you, John. Appreciate that. So yeah, again, Eric Black with USI, specializing as a consultant working with companies and organizations to help them navigate the complexities of employee benefits. And what we're seeing at USI, and our competitors are seeing this as well, we look at a market outlook summary every year where we're looking at some of the key trends and challenges that employers are facing. So what we're seeing is if you look at the renewal increases and the costs, it's no secret that it's very turbulent out there. So we kind of put this into 2 buckets. So fully insured clients, so maybe the smaller organizations that aren't ready to go self-funded. But we're seeing increases anywhere from 18 to 25% increases with Blue Cross, United Healthcare, Cigna, Aetna. So if you think about, an employer, for easy math, are spending $1 million on a employee benefits health plan, a 25% increase is adding an additional $250,000 onto that plan. So we're seeing incredible spikes, very turbulent out there, and we're seeing some that are much higher than 25. We're seeing 50s, 60s. And this is being driven by higher claims. Severity is increasing. Some of the provider contracts, inflation. So we're seeing that in the fully insured market. I think John mentioned, what are employers seeing with that chart a few slides ago. With the larger self-funded clients, I would agree that we're seeing more along the lines of high single digits, 8-9% increases, depending on how the claims are running. So unprecedented renewal increases. Pharmacy costs, again, no secret here. Specialty drugs are now exceeding 50% of your total RX spend. We see all the GLP-1 advertisements and commercials and social media. So this is certainly a high topic. High cost drugs putting heavy pressure on budgets. Once upon a time, the pharmacy was a relatively small piece of the pie, and now it's growing substantially to where in some cases it's 50-50 between the health plan and the pharmacy plan. So we're seeing that. John mentioned this, and we'll look at a slide. for some of USI's book of business, but chronic conditions are driving claims. So obesity-related conditions, diabetes, cancer, heart disease. And we'll look at some of these conditions in the different age brackets and see how the younger generation is experiencing different types of claims than the 65 plus. And then compliance and regulatory concerns. AI is certainly a big topic. So these are some of the things that we're seeing in the market. Again, it's not just in Charlotte or North Carolina or the Carolinas. This is really a countrywide issue that we're facing. In that same breath, what are the considerations? What are some of the organizations looking at? So evaluating alternative funding. So looking at whether that's level funding, self-funding, reference-based pricing, ICRAs, narrow networks. These are all things that companies now are faced with, where before, when you're getting 4, 5, 6% increases, it's easy just to hit the accept button and move on. Now companies are facing these double-digit 25, 50% increases. It's all right. Let's get to the drawing board and figure out what's the best way we can scale this into the future. So it's really looking at a holistic approach to their whole benefits package with the cost increasing. Pharmacy, again, if you looked at that insight slide where you're looking at the pharmacy costs are surging and you're self-funded, you have opportunities to really dig into that pharmacy contract and do audits, explore different formularies, tighten prior authorizations, look at rebates. There's some legislative items going on right now as it relates to pharmacy. Now, unfortunately, if you're in that fully insured bucket and you're a smaller employer, you really don't have a lot of control as it relates to pharmacy. You're kind of stuck and forced with that contract that the Blue Cross and the Cignas offer to you. Primary care engagement, we see that as a huge opportunity to have a relationship with that PCP, so they're directing you to the best care, the best quality providers. Looking again specifically at that GLP-1 strategy and how that's impacting your overall plan, and then compliance and reviewing different compliance and legislative issues. So those are some of the things that we're seeing when it relates to that 65 plus population and employees. We'll look at some solutions here in a little bit. So here's kind of a breakdown. Again, this is based on USI's book of business. We have over 500,000 clients across the U.S. Here specifically in North Carolina, we have roughly 435 clients of all sizes. So if we look at this and we look at kind of that monthly spend, and we look at the age brackets there on the left, we're looking at under 40, we're looking at 40 to 64, and then 65 plus, which brings us to the topic today. But we can see those increases. If you look at your medical under that age 40, it's about $804. RX 213, so a total spend of about $1,017. That middle age bracket, 40 to 64, we combine the medical and RX, a slight increase. But man, look at that jump up with that 65 plus population, where it goes from the younger folks being roughly $1,000 per member per month to almost $2,000. So you can see that 65 plus population is drastically impacting that overall budget when it relates to your health and welfare plan. If you look at some of the conditions, I'm not sure if you can go, okay, there you go. If you look at some of the conditions that are really impacting the health plan, again, you're looking at that under 40 bracket. So back pain, so back troubles, congenital anomalies, asthma, major depression. That's no secret that folks have been struggling, and people are really enhancing their EAP, employee assistant programs. If you look at that middle bucket, that 40 to 64, you got blood pressure, hyperlipidemia, diabetics is a big cost driver. Back pain shows up again. But here we go with the 65 plus, and that is hypertension, hyperlipidemia, osteoarthritis, so wear and tear on the joints, the knees, the hips, the hands, and diabetes. So you see here that these are the conditions that this 65 plus group is really experiencing.
Okay. So let's talk a little bit about what Catapult has been seeing. Catapult is an employers association, as I mentioned earlier, and we have about 1,900 employer members. So we get to see a little bit of everything. We're based in Charlotte, North Carolina, but we're really throughout throughout the states, mainly in the Southeast region. And because we're an employers association, we have a lot of employers coming to us with lots of different questions, from compliance questions to human resources questions, etc. And then of course they also reach out to us with their benefit questions. How do they enrich their benefits package? How do they treat employees according to the laws and the regulations of the DOL, etc. We do get to hear a lot about, now that we have employees that are getting ready to be Medicare age, how do we handle that? So let's talk a little bit about what we are seeing and what we're not seeing within Catapult Employers Association. What we're not seeing and why it matters is that most of our members are not fielding us with a ton of questions on Medicare related issues just yet. And there's different reasons. One of them is because employees tend to wait 6 to 12 months before turning 65 to really start engaging and thinking what the next steps are going to be, if they're going to enroll in any other part of Medicare, if they're going to continue to work, etc. Medicare tends to feel like it's something that you can do later until all of a sudden it's right on top of you. And most employees will delay having those conversations. The HR teams are also going to, or what we see is they tend to delay those conversations as well. And I think the main reason for that is that they just don't want to give wrong advice. Sometimes we think that HR or our human resource department should know everything and they should be experts in everything. But most of the times they're not. They're experts in very specific things, but things like Medicare, things, like a lot of compliance issues, those they outsource it. They outsource to experts like Eric, like John, like many of our advisors and specialists at Catapult. So that's what we're not seeing. What we are seeing and what the patterns that we're seeing within our members is that now they're starting to ask questions. Because like John said, and probably like we all know, the tide is shifting and we're seeing more and more older individuals stay in the workforce. And then of course you have the baby boom. So you just have a lot of people turning 65 a lot faster or sooner than we had in the past. So now HR teams are starting to think, okay, what happens when someone ages into Medicare? We're getting the questions of what do we do now? We get questions like, can we still help without offering a group plan? So like a retiree standalone plan. How can they avoid like, how can they avoid compliance issues? Because if you know a little bit about HR, you know that you can't push anybody out of your group health plan into Medicare. So HR, our HR contacts are, the directors, the managers, etc., are starting to ask us, like, how can I be of advice without getting into a compliance hole? So this is showing us that there's a lot of growth in interest for Medicare strategies and solutions. We're starting to hear like, okay, tell me how we can budget. Tell me more about retiree HRAs. Tell me about Medicare premium reimbursement strategies. Tell me about Medicare budget strategies, things like what we're going to talk about in just a little bit with John and the corporate strategy. So our members are not asking a ton of questions, but they're starting to ask very strategic ones of how do we move forward? Because we know that all of this is coming our way. And of course, most employers want to take good care of their employees. John, if you can go into the next slide. Thank you. And I say all of that, but of course, the market data like definitely explains the shift. Um, since 2020, we have seen a growth in ICRAs, which is the individual coverage health reimbursement arrangements, and these are for employer groups 50 or under 50 or over 50. We've also seen a huge intake on QSARAs, the Qualified Small Employer Health Reimbursement Arrangement. And these are very specific accounts. They're for employers that have under 50 employees or less. And since 2020, these things have increased by 1,000%. Of course, they only started in 2019, so 1,000% seems reasonable when you go from zero to, 1,000. Um, in 2025, over 260,000 employees were offered these types of coverages. Now, these are not just Medicare related coverages. This can be for any kind of insurance premium reimbursement. But just by seeing this, we can see that employees or employers rather are looking into ways to help their employee population, their entire employee population, not just those under 65. So what do we recommend based on what we're seeing? We recommend that you normalize Medicare conversations earlier. So this is when employees start, when they turn 63, or I would even say 62, they'll wait till they're 64 and a half or just a few months before their 65th birthday. Also, we recommend that you separate the education from the enrollment guidance. So typically open enrollment, it's a very busy, very hectic, lots of information being thrown at the employees. You want to make sure that you separate a different time to talk to those Medicare eligible employees or those employees that are getting ready to be Medicare eligible so that they can have the information kind of like in two different sections and not get overwhelmed. And then lastly, partner with a specialist. Instead of expecting HR to be the Medicare expert, partner with someone like John, speak with someone like Eric, someone that's actually going to be able to help you find a good strategy, good solutions, and still stay under compliance. And solutions is what we're going to talk about next. So John, you're going to talk to us about the corporate strategy first, I believe.
All right. Thank you, Martha. Yeah, what we're going to move to now is we've created an overview of the issues that we're all grappling with. And now this next section will be about some solutions to consider. And the first one we're going to focus on is considering Medicare as a corporate benefit strategy, which is a unique mindset for most employers. They don't think of it that way. But with all the numbers that we just reviewed, this is something that we believe most employers should be thinking about. Unless you have a very young population, you're going to see more and more people that are in the Medicare eligibility range. And so why? Why do we recommend that? Well, first of all, as we mentioned earlier, it is one of the 7 cost drivers today and will become even more important in the next few years. Secondly, it's the fastest growing population among the workforce. So this is growing to 10% in 2030 and higher beyond that. It's a much more expensive population. As Eric showed you with some hard data from their book of business across the country, they showed about a 2 times greater cost for those over 65 as compared to those younger, depending upon the industry, like manufacturing, higher education, government. Those, because they have more older people, they're more like 2.5 times more expensive. You have members that like Medicare. There have been several national surveys comparing Medicare members to employer-sponsored care members and Medicaid and so forth. And the members really like Medicare, and you can see about 50% of them rate their coverage as being excellent. Part of that reason is because Medicare has an unfair advantage. Unlike a traditional group health plan, which really needs to keep all ages in mind, because it's not just employees, it's the spouses and the dependents, some of which are newborns. And so a group health plan really needs to think about people that start from the beginning of life to ones that are older than I am. And that very broad range is a challenge, and one that employers are grappling with on an ongoing basis. Medicare doesn't have that problem. That's their unfair advantage. They don't have to worry about NICU days and maternity care and pediatric care. They can exclusively focus on what is most concerning to the people that are over 65. And they want to keep those people healthy by offering them specific set of benefits that will help them as they try to maintain their health when their body is declining. The other reason is really using Medicare and leveraging Medicare as an employee benefit strategy offers the best of both worlds. You can retain experienced, very valuable employees, but not necessarily have their healthcare costs. Those can be moved over to Medicare. You can think of Medicare as being an alternative funding mechanism for healthcare costs for your employees. So how do we leverage Medicare and use it as a employee benefits strategy? Well, it all really involves, we believe, in implementing a corporate Medicare plan. And it's a plan that involves a partnership. Obviously, it's very difficult for the HR team and any employer to keep up with all of the changes that Medicare experiences year in and year out. So having a third party that's really has an expertise in Medicare is invaluable. And they also can offload some of the questions that come into the HR department on a regular basis about people thinking about Medicare. So it's not only an expertise, but it also is a reduction in the time spent by your HR team. So what does it include, this corporate Medicare game plan? Well, some of the features are, first of all, the objective. The objective of this plan is to help each individual find the coverage that is best fit for them. When you achieve the age of 65, you now have an entirely new suite of options. Many folks think of Medicare as being one stagnant plan. It's not. There are 40 to 50 different types of options depending upon where you live. And the objective here is to help them look at all of their options, including the group health plan, to figure out which is the right one for that individual. The plan should be customized. Each employer is unique. Their culture is unique. Their profiles of employees is different. The claims experience, obviously. So it should be customized for each employer. It should be comprehensive, not just looking at the employees that are over 65, but their dependents as well that are over 65. And as Martha just pointed out, you want to start educating and informing people before they hit 65. So this plan should take into account all of those different employee segments or dependent segments. It's proactive. As I think Martha mentioned, typically HR would start to receive individual employees that are approaching 65 or over 65 with questions. And that's great, but really it should start earlier, and it should be involving more than just the proactive employees. And so the plan should be proactive. It's not waiting for employees to start asking questions. It's informing and educating long before that point. It involves a communication plan that informs, educates, includes testimonials, self-service tools that people can utilize at their leisure. And it also involves personalized guidance, one-on-one access to a licensed Medicare advisor who's deep knowledge in this and who can help them be able to do that side-by-side comparison between their group health plan on one side and the various Medicare options on the other side as well. The results that an employer should expect from a Medicare game plan It's a quick and dirty way to look at it is the national average in terms of an employer cost per 65 plus individual is about $17,000 this year. Obviously, we'll be going up quite a bit between now and 2030. We believe that a Medicare game plan can help transition between 20 and 40% of those that are over 65. And when you do the math, depending upon how large your employer is, that could be substantial. The cost to employer, it's primarily from the savings realized. So it pays for itself for the most part. And so it doesn't require a large new budget. It's going to be paid for because you're going to be saving money. And that's what the payment for the cost of a game plan like this is derived. So I will turn it over to Eric.
Thank you, John. I love that. The Medicare is a corporate benefit strategy. So I wish there was a magic solution, a magic bullet, so to speak. But if we're, after listening to, the numbers and the statistics and some of the high claimants, if we're in agreement that if I kind of put this into a couple of different buckets, cost control. So we're reducing claims costs, stabilizing premiums by shifting this population to Medicare, better tailored coverage. So often this Medicare provides that plus 65 with better coverage for their needs, compliance, which Martha talked about, and then it gives employee choice. So partnership. That's what I would say. As you're looking at this, it's not a Band-Aid approach where we've all seen, I've got this employee that's 65, we've got a population of a couple and we just deal with them individually. It's really partnering with someone that has a holistic corporate benefit strategy, as John mentioned. It's a way that USI is approaching this increasing cost.
So let's talk a little bit about health reimbursement arrangements. But before I dive right into that, just remember that we have the chat feature, the Q&A feature. So if you have any questions from everything that you've heard until now, please add them in the chat. Would love to, be able to answer those questions and dig in more into, anything that you're seeing, any questions that you have. So let's talk a little bit about health reimbursement arrangements. These have been around for quite some time. Typically, they started as just that, a health reimbursement arrangement, and they were tied to group health plans and where employees or employers rather wanted to help employees help offset some of their deductible expenses, their co-pays, etc. That's how they started, and they like everything else in healthcare, I think it just expanded, right? So how can we do more? And this is where the ICHRAs, the QSERAs, and the retiree HRAs come into play. Now we'll focus on the ICHRAs first. And ICHRA is an individual coverage reimbursement arrangement. And ICHRA is specifically for any employer size. So you can have under 50 employees, you can have 1,000 employees, you can be part of an ICHRA plan, or you can set up an ICHRA plan. However, it does have classes, and classes are employee classes. So like your full-time employees, part-time employees, those type of employee classes, and it can coexist with a health plan. So for example, if you have a group health plan with Blue Cross and Blue Shield, but you also want to open up an ICHRA for, like, say, full-time salary employees, you could do that. You could have those two benefits kind of like parallel to each other. You just have to make sure that the employee that falls within that class is not offered both benefits or both plans, rather. So, you can use an ICHRA along with the group health plan. You just have to keep in mind those employee classes. Minimum class sizes are required. And really, the bigger you are, the larger you are, the larger those minimum class sizes must be. And then there's a bit of flexibility for Medicare. With the ICRAs, the complexity is a little moderate, so you have to, or you should have a third-party administrator taking care of this for you because there are some compliance things that you have to keep in mind. For example, you have to send your employees that are part of the ICRA a letter letting them know that they're part of the ICRA plan and what that is going to look like on their side. So those are the things that you kind of have to keep in mind with if you're going to offer an ICRA plan. Also, I'll segue to QSERAs. You also have to keep in mind that there is an employee letter that you must share with your employees that you're going to be offering a QSERA. Now, QSERA is a qualified small employer health reimbursement arrangement, and this is for companies that have 50 employees or less. It cannot be part or it cannot coexist with a group health plan. So if you're offering Blue Cross Blue Shield, Aetna, Oscar, whoever, you can't have a QSERA coexist with that plan. It has to be QSERA only. And the QSERA funds are going to cover Medicare age employees, but also any employee as long as it's an eligible employee. So it could pay for a marketplace plan or a plan bought directly from, let's say, Blue Cross and Blue Shield or one of those. So that's one thing to keep in mind. There are no employee classes because, again, it's for small employers and it can't coexist with the group health plan. The minimal classes, obviously, it doesn't apply because it doesn't coexist with this. The complexity or of the QSERA is low, but there are some compliance things that you have to keep in mind, like plan documents, the affordability rule, the notices that you have to share with your employees, and the Medicare flexibility is high, right? Because you can offer this QSERA benefit to any employee. So the flexibility for Medicare is going to be very high because you can offer this type of benefit to your Medicare eligible employees. And then the retiree HRA, this is specific to employees that are no longer part of your active workforce, but you do want to take care of them after they have retired. And this is for a group of any size. So employer size doesn't matter. It can coexist with a group health plan because, again, these are no longer active employees. These are retiree employees. The classes don't really come into play here because it's based on retiree status, not on employee class. And obviously, there's no minimum classes. The flexibility for Medicare is moderate, obviously, because the employee can't be an active, or because the individual can't be an active employee, and the complexity is very low. So it's basically the eligibility would be something like if you worked for our company for, say, 30 years, you're eligible for the retiree HRA. That's going to help you pay for your Medicare premiums. QSERAs, ICRAs, retiree HRA plans, they're all good strategies to implement if what you're trying to do or if your goal is to help your employees, help your retirees. At Catapult, we administer all of these types of accounts. So I know I gave you a very quick, very broad overview of what they are. But if you have any questions, of course, my contact information is going to be at the end of the presentation, and you're more than welcome to reach out to me. With that, let's go into our Q&A, unless, John, you have anything else you'd like to share, or Eric, anything that you'd like to share.
Yeah, I'd like to hear from our audience. So why don't we go to Q&A to make sure they have the opportunity to ask their questions.
Sounds good. So the first question we have here is, if an employee decides to leave a self-funded group health plan to enroll in Medicare, can their spouse, who is not Medicare eligible, remain on the group health plan? I think that was for you, John.
Yeah, that's a question that I hear quite a bit because it's an issue that many older employers are grappling with. I want to make sure my spouse is taken care of if I decide to move over to Medicare. I should start off by saying I'm not an ERISA lawyer. So that's my caveat, but I've talked to several. And the response to that is there is no federal impediment to keeping the spouse on the group health plan, even if their active employee moves over, who is Medicare eligible, moves over to Medicare. It really comes down to the plan that you, as a self-funded employer, might have in place. So you want to make sure that that allows for something like that. Some folks have it that way now, some don't, but could change the policy for their plan, something they would want to work with their employee benefits consultant, someone like Eric, and with their administrator, their benefits administrator. But there is no impediment from a federal level, and it's just up to the employer-sponsored plan.
Next question is for you, John, as well. What is the first step to start a corporate Medicare strategy?
I would recommend that the first thing that an employer would want to do is get a handle on what kind of a scope is this issue for them, and that's pretty easy. Just get a census report. The mistake that a lot of employers make is they focus in on, okay, how many employees do we have over 65? Well, that's only half of the equation. You need to know that, but you also want to look at the dependents, as we were just talking about a minute ago. But even equally important is you want to see how many folks that you have in that 60 to 64 age range, because that's the tidal wave that I think Martha was referring to earlier. You want to get ahead of that tidal wave. So you may have a modest number of people that are over 65 this year. But next year may look completely different because you have a lot of people that are 63, 64 that will be coming down the pike. So I would suggest that's the number one step that any employer should take. Beyond that, if it looks like there are a substantial number of people in those categories, then finding someone that you can work with who has deep Medicare expertise and is used to working with employers. Certainly, they should talk to their employee benefits consultant from USI or wherever it might happen to be. And they may know of people that have a deep Medicare expertise that they would recommend for the employer. So I think that would probably be step number two.
Hey, John, I see another question. And again, probably you're best to answer this, but we've talked a lot about the cost savings and the strategic play here. What about the employee experience? The question is, how do you ensure employees feel supported rather than pushed off the group plan?
Yeah, well, certainly you definitely don't want them to feel they're being pushed. That would be a violation of trust and their requirements under ERISA. So this isn't about pushing or shifting or none of those adjectives. This is all about helping them get to a point of informed decision making. The right answer could be that they stay on the group health plan. And if that's the right answer for them, that they decide, that's great. They can stay where they are. But most people who haven't yet gotten to that Medicare eligible stage, they don't really understand what the opportunity is there. There's a number of misconceptions. Number one is, oh, Medicare is for when I retire. Actually, no, it's Medicare is there when you turn 65. Doesn't matter if you're working or retired or what, it's there. So it's informing them so that they can get to a point where they've got everything laid out in front of them, all the different options, and then they make the best decision for them. And it's not a universal best decision. It's going to be a very personal decision. And so more so than probably ever before, they're going to have one-to-one guidance with someone who can help them get to that point, which is a much different world than they've experienced in the past with a lot more options than they've ever had in the past. So it really is helpful to have that one-on-one guidance to get to that informed decision-making point.
Taking from that, there's also a question of what are the common misconceptions that employers think about Medicare and their corporate benefit strategy? So you spoke a little bit about the employee misconceptions, but what are some of the employers' misconceptions?
Yeah, what we run into quite frequently is the leadership, whether it be in human resources or the C-suite in general, is that many of them have never experienced Medicare themselves. And so some of the same misconceptions that employees might have might exist with the senior leadership of a company. And so they might think that, either I can't talk to anyone about Medicare because that's a personal decision. That's not true. You can, you just have to do it in the right way. They may have a misconception that Medicare is kind of one standard plan throughout the entire country and it's pretty simple. And again, it's a personal decision or not, when in reality, it's not simple. It is far more complex with a multitude of different options. So individuals really need assistance. Not only do you have, depending upon where you live, 30 to 50 different options to choose from, it changes every year. It's not static. And so Medicare is always fine-tuning what they offer and what the carriers that are working with Medicare offer. And so there's a complex situation that is evolving, which really layers in a lot of complexity to the overall decision. So I think those are the two major misconceptions. How can I communicate about this and help people? And how can I make it easier for them to make the right decision? I think even employers have that misconception as well.
Thank you. And then the final question is about ICRAs and QSERAs. And the question is, are ICRAs and QSERAs like a stipend? And the answer to that is no. ICRAs and QSERAs are not a stipend. These are employer-funded accounts. They require plan documents. They require non-discrimination testing. But the beauty of them is that they're tax advantage. They're tax advantage plans. So unlike a stipend where you give cash to your employee for health insurance or say Medicare premium insurance, a stipend can be used for anything. So your employee can get that stipend through a check or a direct deposit and they can go and buy shoes because there's no proof required that they did use that money that you gave them for a health related reason. Where ICRAs, QSERAs, they are, because they're managed, and of course they have plan documents and they have to be under compliance rules, the funds are specifically for insurance and medical expenses. Proof is required. And again, there's that tax advantage component where a stipend, at the end of the year, when you start creating those W-2s, you have to add that stipend money as payroll or as income. So it's two different types of things that you have to keep in mind. Do you want to give a stipend and then pay taxes on it and then have the employees use it for essentially whatever they want? Or do you want to really limit the funds that were the benefit that you're offering your employees, limit it to be used for what it's intended for? That ends our Q&A question, but we do have a few minutes. So John and Eric, I don't know if you want to give a few parting words before we close out.
Yeah, I'll start. This is the journey to put this webinar on involved a lot of great conversations between Eric and Martha and myself. And I've learned a lot about ICRAs and the work that Catapult does. And I haven't been working with Eric a lot prior to this, but the wealth of his knowledge, not just with USI, but having worked with other employee benefits consultants, has been really valuable to my own personal learning experience. So thank you to you both for that, and I hope this has been helpful for the audience.
Yeah, I would just say thank you for joining us today. It's a really important topic. If we look across the landscape of employee benefits and this turbulence that I spoke of earlier with these large increases on the fully insured side and the self-funded side as well, what strategies are you putting in place as an organization with this 65 plus population? Really looking at that strategic holistic approach. We really think there's a value in partnership. And if you want to learn more about USI or some of the things that we offer our clients and help them navigate the complexities of offering an employee benefits plan, please reach out at any time. Thank you, Martha.
Thank you. Thank you, everybody. Don't forget, you're going to receive a survey. It's just 5 questions. If you can take that survey, we'll really, really appreciate it. We hope that you have a great day. Thank you for joining. Bye-bye.
Bye.
Thanks, everyone.